Then they did an anterior chamber phakic IOL A6, phakic 6, which was common late 80s and early 90s. This is an anterior chamber phakic lens. And actually these lenses were recalled from the market. So the patient came to me. She had seen a very good surgeon, and she was coming for the second advice, and this is the first day of changing plan. She was coming and telling me, I went to this professor and he gave me advice to remove the lens only. Of course, the endothelial count was low, and we know this is progressive. So the decision that was taken that the lens will be removed first, then she will be left with the myopia, and she wants to correct the myopia. So the question was, would you remove the lens alone, and this is the recommendation she had, or to remove it with the lens, refractive lens exchange? And this was my decision, and I had to talk to the patient and tell her, and we will go back to the panel after finishing. So you have some challenges. First, I have to remove the anterior chamber phakic lens that have been there for many years. And so I started with a scleral incision to decrease the possibility of inducing astigmatism. And the first thing you will think that you will grab the lens and go out. But once you check, I checked it, there was synechiae at the foot plates of this anterior chamber lens at the angle. So you change plan that you have to cut the haptics, and then cut the haptics again, smaller pieces, and try to slide it out from the synechiae. And at the same time, after doing this, you can open the angle where synechiae will zip on the angle with viscoelastic, like gonio viscolysis. So the first step is I talk to the patient, I will do both techniques, and I will give you my reason why I will do this at the same time. You have to always be observant to protect the corneal endothelium, and in removing, manipulating the lens, you have to be aware where are your hands, where is your second instruments, how you are dealing, what type of viscoelastic you are protecting the corneal endothelium. So all the time you are extremely careful not to insult the cornea. Then these are the residual parts that at last I could slide it out from the synechiae in the angle of the anterior chamber. And that's the first change of lens. I thought I would remove directly the lens, but here I had to get the haptics piecemeal from the angle of the anterior chamber. And once I got through with this, and now the lens is out with all its fragments and haptics, then I start to tackle the lens. All the time I'm using viscoadhesive to protect methyl cellulose to protect the corneal endothelium, and I use helium or viscocohesive to form the anterior chamber and give me a space to manipulate inside it, doing all these maneuvers, keeping in mind I don't want to lose endothelium. Then I close the wound with the suture so I don't to leak, though it should be self-sealing. And then I chose to do the incision temporal. This was the steeper meridian. This wouldn't change much of the astigmatism. This is a 2.2 millimeter keratome. And then I go into cataract, doing the cataract. In removing the lens here, you have always again to keep in mind this is a high myope, you don't want complications, and you want to protect the endothelium. You first aim to protect the endothelium, and secondly, you want to be careful not to go into other trouble like opening the posterior capsule inadvertently. You don't need more complications. So I do hydrosection, and then almost with no power, here you utilize phacoaspiration at its maximum. You're not using ultrasound. You can see even the big bubbles are not moving, which means you're protecting the endothelium. Usually there are trapped very fine air bubbles that give you an indication how much you're insulting the endothelium. You don't need ultrasound. Even if this was part of the lens, you would use minimal ultrasound. With using bimanual irrigation aspiration, you see the irrigating cannula is directed posteriorly to inflate the posterior capsule and open the bag, and as well to decrease the turbulence at the corneal endothelium level. Then I will implant the plant lens. This is a hydrophobic acrylic lens, implanting it in the bag. This is a 13 millimeter overall diameter hydrophobic acrylic lens. And then I'm going to follow with closure of this corneal wound, because I don't want any possibility or risk to have a fluctuating anterior chamber for any reason that will jeopardize the corneal endothelium. And you see the opening of the pupil post-op, you see the cornea is crystal clear. The opening of the pupil due to the presence of the haptics of the anterior chamber for a long time, and the synechium, this stretches the pupil and sometimes can induce ischemia in areas, and this is a well-known phenomenon we know from anterior chamber lenses in general, whether phakic or aphakic. So this was my case, and I just want to rationalize why I chose to do this.
You depended here on the count of the cells. Why don't you think that the morphology of the cells and the pachymetry, not in this case because this is an ectasia case, but usually the morphology of the cells and the pachymetry, the thickness of the cornea, maybe will give more valuable information about the status of this.
Yeah, I agree. Just putting the number for as in the presentation, just to give an indication. But it's not only the number, the shape, the polymegatives, and the thickness of the cornea. Of course, I agree with you. But at any state, the reasoning why I did this, because doing a surgery, you insult the endothelium, definitely. So this patient, we know, has a progressive problem, and she will need later on refractive lens exchange or cataract extraction. So if you do with one insult, losing whatever amount of endothelium you're going to lose, taking all the precaution, in my opinion, this was much safer for the patient rather than doing two surgeries. And it took me a lot of chair time to convince I told her this is my opinion, the other opinion is not wrong, but if I'm going to do it, I'm going to do it this way. And actually, the result was as I wanted.
We always get this question, what about the other eye? If the other eye, she has the same lens?
No, the other eye, she didn't do phakic. It seems she was asymmetric. She had LASIK and she's okay. She doesn't have LASIK.
I'm talking about similar cases because actually I was one of the accused surgeons who did lots of the surgery in the 90s and actually regretted the war. And actually, they all came back with trouble. This was the first phakic IL for myopia we got in the world motion.
Yes, we did all use it.
And actually, they came back with problems, either corneal compensation, iris atrophic changes, synechial and cataracts. But sometimes you get one good eye and one bad eye, and the patient is always worried to leave the other lens inside.
So my question,
would you recommend removing it and doing clear lens extraction?
Yes.
Most of them come back after the refraction.
Yes, I would. If she had the same problem, other eye, I would do the same. But I would ask the panel, would you do it separate sessions or same session?
One answer only, and then we shift for another speaker.
Yeah.
So, do I want to take this question?
I think there's quite good evidence that every time you open the eye, you accelerate the endothelial cells. So I think one session is preferable if you can. I would have perhaps used a soft shell technique.
I did.
You did. So that you did the product, you pointed out the levels. And I might have used iris-focus just to keep the people in, because in these cases it always looks small. Yeah, I would recommend more.
Thank you very much. Now we'll shift for the next speaker, Dr. Haika.
second one. I have two quick cases to show. This is the first one.